And we will start at 2 minutes past 3, just waiting for a few more attendees to join. Then we can begin the webinar. Good afternoon, everyone, and welcome. Thank you so much for joining our webinar today. My name is Sasona Buyeye. I am the Communications Assistant in the IBIS Reproductive Health Africa Region Office, and I will be your facilitator today. Our webinar will start now and should end at 4 o'clock on the dot. Thank you so much again for joining. So this past Sunday, the 16th of June, marked Youth Day, which was a day dedicated to commemorating the contributions made by young people in the struggle for freedom in South Africa. What started as a peaceful mass rally against the Afrikaans medium decree by 3,000 to 10,000 learners on the 16th of June, 1976, soon escalated into violence and tragedy when police opened fire. This day is commemorated to honor the young lives lost and to recognize the incredible bravery of children, some as young as 12, who stood up against an oppressive system. To commemorate this day, we are pleased to host this webinar to share findings on a research study authored by our IBIS researchers, Joel Mathasia, Teho Besanar, and Sarah Baum. The study to be presented today is titled, "What we mostly focus on is preventing pregnancy. We don't really focus on preventing HIV. Young people's perceptions and priorities when preventing unplanned pregnancy and HIV." This presentation will highlight the challenges that young people in South Africa continue to face when dealing with HIV and AIDS and unplanned pregnancy. A link to the paper will be shared in the chat and distributed to everyone after the webinar. Allow me to introduce our speakers. Our first speaker for the day is Tanya Robertson from IBIS Reproductive Health. She will share with us an overview of the research findings, young people's perceptions and priorities when preventing unplanned pregnancy and HIV. We will also have Nga Murombedzi from the AIDS Healthcare Foundation, who will be sharing with us the destigmatization of HIV and AIDS and its impact on young people. Our third speaker of the day, Mandy Batlanyane, who from Ubushabami Futuyim Law, will be sharing medical practitioners' perspectives on young people's when preventing unplanned pregnancy and HIV. And our final speaker, Niko Kubai from Y Plus South Africa, will be sharing anecdotal of young people towards the prevention of HIV and AIDS and the treatment of it. Thank you for availing yourselves for this insightful event. And without further ado, I will hand over to our first speaker of the day, Tanya Robertson. Thank you so much, Tanya.
Thank you, Sasona. If I could ask you to please share the slides. Perfect, thank you so much. Okay. So good afternoon, everyone, and thank you to Sasona for the introduction. As Sasona mentioned, I have the pleasure of presenting on the work of my colleagues, Jules Mathasia, Tsegofaso Besana, and Sarah Baum this afternoon on their research relating to young people's priorities for preventing HIV and unplanned pregnancy. Next slide, please. Okay, please take a moment to familiarize yourself with some of the abbreviations we'll be using. Most notably, we will be using the abbreviation YP to refer to young people. And then just a quick note on terminology. As you might be aware, dual protection refers to the simultaneous use of a barrier method and a contraceptive method to prevent both pregnancy and STIs, which of course includes HIV. And an example of this would be using both a condom and a contraceptive pill. And then the term unplanned pregnancy is used in the study, and it refers to either contraceptive failure or to the non-use of contraceptives when one does not desire to become pregnant. Okay, next slide. Okay, so some background for the study. The dual burden of HIV and unplanned pregnancy remains a persistent issue among young people in South Africa. This is evident in statistics such as that 5.5% of young people were living with HIV in 2021. And we saw during the COVID-19 pandemic, there was a notable rise in birth rates among young people. Additionally, approximately 30% of young women have reported an unmet need for contraceptives in South Africa. Now, despite the policies and interventions implemented by various stakeholders, the awareness and uptake of PrEP, which is pre-exposure prophylaxis, and dual protection remain low among young people. Next slide, please. The aim of the study was to explore how young people perceive, prioritize, and act to prevent both HIV and unplanned pregnancy. During data collection, 8 focus group discussions and 3 in-depth interviews were conducted. The participants included 54 young people, aged 18 to 24 years, of which 27 self-identified as male and 27 identified as female. These interviews and focus group discussions took place in KwaZulu-Natal, the Eastern Cape, and in Gauteng. And participants were recruited using snowball sampling in collaboration with a local recruitment partner. The data was collected between May and June in 2016, and thematic analysis was used to analyze the data. Next slide, please. Okay, so the results fell into 4 main themes, including contraceptive knowledge and use, perceptions of unplanned pregnancy among young people, pregnancy prevention as a primary priority, and young people's perception of HIV risk and prevention. The findings are presented over the next few slides, and they're accompanied by pertinent quotes from the participants. To be mindful of time, I won't be reading through all of the quotes, but you're welcome to do so as they are displayed on the slides. Next slide, please. So under contraceptive knowledge and use, most of the participants demonstrated an understanding of the risk factors that contribute to both unplanned pregnancies and HIV contraction, such as unprotected sex. The respondents also indicated a preference for using short-acting contraceptives, such as the injection and contraceptive pills, over long-acting reversible contraceptives. Despite this, however, most of the respondents had never heard of dual protection before. This is evident in the last quote on the page, which reads, I don't think we know because generally and honestly, this dual protection thing is not promoted at the clinics. Next slide, please. The participants also expressed complex and varied views regarding unplanned pregnancy. Most of the participants regarded unplanned pregnancy as problematic, and they highlighted the negative impact it can have on young people's education, such as having to drop out of school to take care of their child. On the other hand, a few of the respondents raised the fact that unplanned teen pregnancy has become normalized and even trendy among young people, as it is increasingly common. Next slide, please. Two of the young people who became parents in their teens shared the challenges they experienced, such as having to compromise on their educational aspirations, as well as their self-esteem or reputation being negatively affected. A teen mother from Gauteng shared, "It was hard. I wanted to do so many things, and falling pregnant was a step back. I wanted to further my education because I had already finished matric when I fell pregnant. I didn't because I was pregnant. You know, sometimes you just tend to give up on yourself and put yourself down self-esteem wise. So it wasn't nice at all. I felt like a failure, and it's hard to pick up from that." Next slide, please. A notable finding from the study was that preventing pregnancy is a primary priority for young people when using contraceptives. This was due to the long-term financial burden and responsibility that they associate with parenthood. As one young person from KwaZulu-Natal phrased it, "What we mostly focus on is preventing pregnancy. We don't really focus on preventing HIV because most of the time we focus on family planning. You feel that you get the injection, why use a condom? Because I have already got the injection and I won't fall pregnant." Next slide, please. In keeping with this, another notable finding was that the participants were overwhelmingly unconcerned about contracting HIV, as they did not perceive it as a threat. They noted that many people living with HIV do not show any symptoms of infection, and they live long lives. They also believed that HIV treatment is easy to manage, as it only requires you to take one pill, and that it remains stable over time, unlike some other chronic conditions. One participant from Gauteng expressed, "I think in this day and age, half the population in South Africa are HIV positive, and people don't show any symptoms when they are positive. HIV is no longer a death sentence." It is encouraging to see how much progress we've made in the treatment and destigmatization of HIV, to the point where it is no longer feared by young people. However, this raises the concern that young people's views on HIV have shifted towards nonchalance for the contraction and spreading of HIV. Next slide, please. So in conclusion, we noted that the young people in this study rank the prevention of unplanned pregnancy as their primary concern when using contraceptives, while HIV is seen as a lesser threat. We therefore suggest youth-focused interventions which target both unplanned pregnancy and HIV prevention in order to respond to young people's priority of managing their fertility while simultaneously encouraging holistic sexual reproductive health goals. One way that this could be explored is through combined biomedical therapies which target both of these areas. The promotion of build protection also needs to be reinforced through creative and relatable messaging, which can be achieved by including young people in the design of messaging and interventions. Next slide, please. Okay, please refer to this slide for our list of references. Next slide. Thank you for your time. I will look forward to questions at the end, and I'll revert back to Sasona for now.
Thanks so much, Tanya. I will now hand over to our next speaker, which is Nga, and she'll be sharing with us her thoughts on the destigmatization of HIV and AIDS and its impact on young people. Over to you, Nga.
Thank you very much, Sesona, and thank you, Tanya. I enjoyed listening to the voices of the young people coming out, and often within the work of HIV and AIDS, both from prevention to treatment, the young people are not represented. And I want to pick up on a conversation I participated in earlier, and it resonates with some of the findings through the quotations that Tanya spoke to. And it was firstly the normalization of teenage pregnancy, then the manageability of HIV and AIDS. So basically, HIV and AIDS is no longer a death sentence, so young people do not fear it. In line with that, and as I build into the destigmatization, teenage pregnancy is visible. And so the evidence of his sexual activity is seen. HIV and AIDS, there's a level of privacy that is associated with it. And so young people often hide behind that. However, that leads them to continually reinfect each other or to not find themselves on treatment. So I wanted to comment on that before I get into what is HIV discrimination. HIV-related stigma and discrimination simply looks at how somebody either perceives somebody with HIV and who's living with HIV, or how they act towards somebody living with HIV. The discriminatory part of it is the experienced reality for the person living with HIV. The stigmatized part of it is the prejudices that we carry around as we go through life. And so when you look at the intersection of teenage pregnancy and HIV, the presumption or the stigma around HIV is more concealed than around teenage pregnancy. There is also, as one young people I noted here, there is also the loss of self-esteem. With teenage pregnancy, it is more emphasized than it is with HIV. So it's important when we start to look at the conversation, especially the intersection and the prioritization of health elements between teenage pregnancy and HIV and AIDS. And we have to look at what is the conversation that leads to young people prioritizing differently. And so even when we look at discrimination, what have we done in terms of efforts to move away from discrimination of people living with HIV and AIDS? A lot of this is theoretical because evidence shows us that, firstly, young people sometimes do not go to facilities because of discrimination. So within facilities, there is a narrative around young people's sexuality and the perception of seeking treatment, seeking testing services, or even seeking condoms. So the one thing we have to be mindful of, especially when we're looking at dual protection that links to discrimination, is what is the health attitude towards the other part of the protection? We know that as per the Termination of Pregnancy Act and our laws, a young person can seek contraceptives at the age of 12 years old without the consent of a parent. However, within schools, you cannot test a learner without the consent of their parent. Now, it looks to even the attitude of parents in terms of testing versus the attitude of parents in terms of contraceptives. And we want to, as the proposal was here, we want to demystify why that is. When we are looking at discrimination, we're also looking at the mental impact. Which of the two do young people think is more manageable? HIV is a lifelong virus. You live with it for the remainder of your life. Having a child, one parent stated that having a child means the young person can continue with their life, but as is the culture of our context and our social realities, young people are giving their children to their parents. So it's almost as if a pregnancy can be detached at the end of it. You give birth, or you can terminate a pregnancy, and from there you can be exonerated from the responsibility that comes out of that. That is not something that is the reality for people living with HIV and AIDS. And when we also then look at how long can you then move on with life without people, there's an issue of disclosure, without people knowing your HIV status. That is also something that we need to explore. So it's the policies around disclosure, where with HIV and AIDS, with HIV, or if somebody is not taking medication, it builds up into AIDS, you can carry on without having to disclose. You don't have the option of that with pregnancy. It will disclose itself essentially. So we have to look at, it's not just in terms of treatment, but when we look at stigma and discrimination associated with HIV, also have to confront the level of prevention services. So I spoke to that when I was looking at what is the attitude of health practitioners towards young people seeking testing and condoms versus young people seeking contraceptives. Then we also look at their other intersections. So conversations around tuberculosis and other services, so your STIs, cervical cancer, that speak largely to how somebody living with HIV experiences their overall health. Sometimes those are met with discrimination that then feeds into the conversation of HIV related. Now, we have to be within the context of young people because of their mental health, because of the adolescent challenges that they face, because of the youth realities in South Africa, issues such as unemployment, issues such as their understanding and perception of sexuality. We also then have to broaden that to say that HIV discrimination also looks at avoidance behaviors amongst young people. Young people have the desire to be part of a collective. So if there is the perception that they can be isolated because of the behaviors that are around them, that feeds into their risk to prioritize the pregnancy possibility over the HIV because of the narrative that is around. There is gossip, there is potential for verbal abuse, and then there's obviously social rejection. Now, when you're looking at the stigmatizing behavior, we're also looking, especially in this month, but also as we carry on and we advocate for increased sexual reproductive health right expressions and observance in South Africa, we have to look at how discrimination removes a dignified experience of a young person's sexual health rights and overall their health rights. Now, discrimination, evidently, because it translates into the spaces where somebody living with HIV or somebody at risk of HIV needs to get into in order to seek services. Discrimination also has to then be confronted in a way that doesn't lead to physical abuse of the young person, that doesn't lead to denial of health or social services, or as sometimes you find discrimination in the employment or workspace. And also we find that because of gaps in understanding of living with HIV, we get that people are also isolated from educational opportunities, and in some religious circles, they are isolated. So to summarize, when we're looking at discrimination and maybe to speak to the issue of the proposal of innovative ways in which to address this and how to strengthen the dialogue and reinforce messaging on promoting dual protection, the innovativeness that has been proposed of biomedical therapies that speak both to HIV and teenage pregnancy is something that we can strengthen while being mindful of the social realities of young people. We've got young people who are at risk and also making the stage of between pregnancy and HIV, but they are in rural communities. They are outside of school. They are living in abusive situations. So as much as we can advocate for innovative and progressive biomedical therapies, we also have to support that with empirical evidence on the ground, which is why I opened with that. I like that young people are coming to the fore. To extend the experience of discrimination, we also have to understand from young people. So we start even before the therapies, we start from understanding how can we speak to young people and ensure that we reinforce the messaging without taking away the strides we have made towards ending AIDS by 2030, towards reaching 95. One of the drawbacks is, as much as we purport the successes, we run the risk of, as Tanya opened, we run the risk of young people saying, well, I can live a fulfilling life with HIV. And so they then do away with the triple protection that comes from condoms, which is against pregnancy, against STIs, and against HIV. So we need to go back and reinforce and see how can we strengthen that messaging to say and speak to the myths, for example, that condom sex is not fun sex, it's not nice sex. Those are some of the things that also influence how young people are saying, well, if I get pregnant, I've got options. If I have HIV, I live on medication, but my options, I can conceal all the other things that I then have to navigate are in there. Thank you.
Thanks so much, Nga. I will now hand over to our next speaker, Dr. Mandy Mpatlanyane from Ubushabami, and she will just be providing us with a medical practitioner's perception on young people's perceptions on preventing, treatment, and unplanned pregnancy and HIV. Over to you, Mandy.
Thank you so much, Susanna. Thank you so much for having me. Hello, everybody. So I was asked to speak about the perspective of a medic, of my understanding of how the system functions, as well as how healthcare providers and practitioners view the situation. So when I was reading the article, and a few parts in the abstract actually stood out to me, and innovative solution of how to handle both HIV and unplanned pregnancy. And I thought that was a very interesting one, that we are going into that to see how do we handle this population, and how do we create a understanding how delicate this population can be. So I want to start off with saying I'm grateful that that is our piloting starting point, because young people need innovative solutions for a lot of the problems, especially with sexual reproductive health issues. So the two things that I want to hone in on, especially from a medical perspective, is two things that I've observed, especially working with Ubusha education to sort of get the point across. The two main things that I want to talk about is systemic facilities, health facilities, as well as healthcare workers' perception. So I'm going to speak from what I've experienced and observed from some of our work that we've done. So the first one, facilities, is there are barriers when it comes to how young people understand what health facilities are out there for them. And when I say the barriers that are there, is that you find even adults, but with young people, that they will approach the incorrect tier of the health sector for something that they need assistance with. What I mean by that is that there is a call for us to strengthen our primary healthcare sector, because that should be the catchment and the primary place in which people first present with whatever condition they may have. This is excluding emergencies, obvious emergencies. However, when it comes to these primary services, such as accessing contraceptives, such as HIV testing, TB testing, etc., the primary healthcare sector is made for that. So recently at Ubushabami, we had a month where we were looking at clinics, which is also known as Teen Zone. The National Department of Health had rolled this out to have a specific section that was dedicated for teenagers or adolescents. And in these services, they would be catered for when it comes to contraceptives, HIV testing, counseling, mental health, etc., etc. So we wanted to find out, do young people know about these services? And it was very disappointing to find out that not many people even know that there are specific sectors for them in the primary healthcare sector, specifically for the adolescent group. It starts at a specific hour, which accommodates the school time hours for them to show and present. And it has a dedicated nurse who is trained on how to handle young people and how to speak to young people. So the idea that, when you come to the healthcare facility and the nurse is mean to you, or they don't understand what you're talking about, it's always an older lady who just doesn't get what you're talking about. They have dedicated centers that specifically have a person who will understand your troubles and understand what is expected or what young people are looking out for. And there are many other organizations that are also tailoring youth-friendly services so that young people seen as a special population can be catered to. So that's the one barrier that I've noted when it comes to the health sector, and even with second one, the healthcare practitioner's perception. So going back to what we had facilitated as for a month at Ubushabami about this adolescent group, is that we realized that the young people, and I think as the previous speaker just mentioned, how they perceive healthcare practitioners also becomes a barrier and a hindrance for them to seek assistance with certain issues. And we had an Instagram live where we had asked the young people with the nurse present to ask questions about what should they expect from an adolescent-friendly clinic, etc., etc. And one of the big things that they kept on saying was, we want to know, how do we report the nurse? It was to hear that the biggest concern wasn't what the services are or of what the sector can provide for them, but they wanted to find out, how do they pin down and blame someone, or how do they report someone? And to me, that shows an understanding of how they perceive the healthcare workers, that they perceive healthcare workers to be unapproachable, safe space, and therefore they will not seek the assistance from that sector if they feel unsafe in that space. So I think that was a big eye opener to see that that's what young people perceive of healthcare providers such as myself. So just coming to some sort of rounding up. So it is important, and I think what it highlights is the relevance of youth-specific facilities, whether it's in the primary healthcare sector itself, having a clinic for young people, or even more, having other compartments with NGOs or civil society that look at just targeting young people to get them to seek assistance to the family planning regimen, or in HIV testing, etc., etc. So one of the things that I also wanted to highlight that I've seen, especially with working with young people, is that specifically when we talk about what they prioritize in terms of their health, if we're looking at the juggle between prioritizing preventing pregnancy over preventing HIV, I wanted to add an extra, some extra categories that we can also think about that young people might want to prioritize. And one of the things is they prioritize convenience, especially when you look at the health sector. They prioritize convenience. So showing up to a facility and being on time and quick is something that they prioritize. Therefore, if you have to go to a clinic and stand in long lines, that's not convenient for you. So you won't go and sit there for the whole day just to be tested or just to get your contraceptive. So they prioritize convenience, they prioritize privacy, that it is important for them to feel that when I step into this space, it will not be the nurse discussing it with the next nurse next to them or the doctor next to them, etc., etc. And trust needs to be gained when it comes to young people. And then finally, one that I've also seen and advocate for greatly is that they prioritize empowerment. So knowing that they have to own their health and own the decisions that they need to make about their health is also a very big thing. So what this conversation, the ongoing understanding of health being something that is your own responsibility from the get-go. So teaching young people that health is their choice, it's their decision. They need to make the choices for better health for themselves is something that we need to emphasize more and more on a daily basis whenever we interact with them. Even in the school curriculum, when we add in the life skills, this is one of them, to teach more and more about how they need to feel empowered in owning their health. And I say this because in the health sector, we've to own their chronic illnesses, whether it's diabetes, whether it's HIV, or whatever it is. They make it the health practitioner's responsibility to manage the hypertension, to manage the diabetes, to manage the HIV. And that's not how the sector should be working with the people it's providing the service to. They should come also feeling like they have a responsibility for themselves and have a huge role to play in how they are well. So above and beyond, I think, perspective, when we look at the system, it is important for us to understand how we create a system that acknowledges that youth and young people are a special population. You can't group them with the other populations and think they'll figure themselves out. So it is relevant and important for us to continuously create spaces just for them, because in this space they have certain traits and characteristics and specialities that you need to focus on with this specific group. But also when it comes to the healthcare provider, the perceptions, I think we also have a stigma of our own, but the perception that the healthcare practitioner will be unkind, will not understand what you have, I think it is important for young people to know that there is spaces provided for them at the primary healthcare level that will have someone who's dedicated, that understands their needs. And if they can access that, I think it will make it an easier transition for them to see how they get assistance when it comes to family planning as well as HIV testing. Thank you very much.
Thank you so much, Dr. Mandy. Before I hand over to our last speaker of the day, I would just like to remind everyone that there is the Q&A function made available. If you have any questions for any of our speakers who've gone up so far, please feel free to pop them over in there, and we will have a question and answer session after Nyiko has spoken. And without further ado, over to you, Nyiko. You will be giving us some anecdotal perceptions of young people towards the treatment and prevention of HIV and AIDS.
Thank you so much, Sesona. Greetings to everyone who's on the call, and thank you so much to our previous speakers. Well, I just joined on the call. I might have missed most of what the previous speakers have mentioned, but I'll be briefly going through most of the key points that I thought I should prioritize in this conversation. Well, I didn't familiarize myself with the document that was centered around this webinar. So I think most of my views won't entirely be supporting or maybe adding on maybe the success of matching the two therapies for pregnancy prevention and HIV, but I hope it adds to the conversation. So I'll be sharing some anecdotal perceptions of young people concerning the prevention and treatment of HIV and unplanned pregnancies. So, just to go through a brief meaning of anecdotal, it's based on or consisting of reports, observations of usually unscientific observers based on an account given by a person as opposed to scientific in nature, unscientific, qualitative, or circumstantial points. So I am affiliated with Y Plus South Africa, a network of young people living with HIV in South Africa. I'm also affiliated with people living with HIV sector that includes my organization, Tolulwazi Phakathi. And Tolulwazi, we offer holistic psychosocial services to young people who are born or living with HIV, and also reminding those who are negative to remain negative by sensitizing them with the available preventative methods, your PrEP and PEP. So we do host adherence camps per quarter where we offer holistic services to young people who are adhering to their medication, trying by all means to encourage them to adhere to their medications and live positively with HIV. We also have our online campaigns and some in-person campaigns on our Shontwana program, where we mostly focus in dispelling the misinformation that keeps on peddling, especially on our social media platforms where young people normally engage. So I'll first go through some of the general comments or general community perceptions and also recommendations. So, firstly, I would say most young people don't prioritize their health. They are ignorant to the available literacy of preventing HIV and unwanted pregnancies in the name of maintaining their social status or their social validations. And then some of the things that may be part of the conversation may be home background issues. Some of these young people come from poor backgrounds, and some of the cultural norms that may be against these prevention methods. This also speaks to young people's ignorance to politics because they do not feel involved in the process as much as they don't feel involved in designing health interventions that address their needs as young people. And also, secondly, one of my second general perception, I think it would be the lack of social protection merging with our Ministry of Health, since we know that some of the services need an element of social protection, which includes a holistic way of supporting these young people to adhere to their medication after eating a healthy and nutritional food. So lack of food security and social protection to other social basic needs for these young people remain a gap for them to adhere to these preventative methods or even to access the healthcare services with confidence because they know that maybe they won't really benefit as much as they hope to benefit, including that social protection element. And then as I continue, I also heard one of the speakers speaking on the independent consent for young people to access SRH services from the age of 12 or 15, if I'm correct. I think it was 12. But it remains as an unclear conversation, especially in our communities, that do young people really access those services at that early age, or do are young people open to really accessing those services at that age? Can you still hear me, colleagues? Okay, perfect. As I continue, so there's a need to clarify the conversation of parental consent or independent consent for young people to access SRH services. And then I will then go to most of my points that I was hoping to address that speak to treatment, prevention, and pregnancy. So most of these key points are general points that I think most young people conversate around, especially in the spaces that we normally meet in our organization through youth dialogues, through our camps, through campaigns and other platforms where we have young people voicing out their grievances and challenges in accessing local healthcare services. So most of these young people are insecure with how these services are being offered to them, especially in our local healthcare services. They're insecure with these preventative options, preventing unwanted pregnancies and prevention for HIV because of how they are being offered to them. There are no youth-friendly services that prioritize their safety of their information as young people, since we know that this is a population that is mostly fragile to stigma and discrimination. So they really value their privacy and they don't really want to see their neighbors working in their local healthcare facilities. And it also puts their information and privacy at risk, especially when they go back to their communities. So insecurities to the different pregnancy preventative options. And there are also culture driven obstacles that hinder those prevention methods because most of these young people, or some of them, go to traditional healers to access services that they think they would be stigmatized if they would go to healthcare facilities, or rather they just prefer accessing those traditional medicines. And then I also spoke on the quality of youth only services. Like, the quality of these services is not monitored or comprehensive enough to address young people's needs, especially in the HIV and SRH space. So they are not fast, don't feel safe, not fun, and not using the right tools to educate young people. So I think there's a need to have some improvement, especially in that sector of youth only services. And then as I continue, I also wanted to speak on community sensitization. I believe there's some work going on. We have our healthcare promoters going to our communities to promote the services that are being offered in our healthcare facilities, but that information doesn't really reach the targeted population that we want it to reach, because we have old populations doing healthcare promotions, and most of that information goes to few people, and it translates to corrupted information as it carries on, because we know our community members use word of mouth as one of the reliable source of information. So there's a need to monitor our health promotion and literacy, or even sensitization for our community, especially young people. And then the issue around stigma for HIV prevention methods. So most of these young people think these prevention methods are especially for girls, not for males. They are gender biased, they think so. And there's also stigma around the oral pills for preventing HIV infection, the PrEP oral pills. So young people don't really feel like it's important to keep on adhering to your daily oral pills while you are not sick. So they would prefer maybe faster options, or maybe the option that we are proposing in this webinar, merging your prevention therapy with your HIV therapy, making it one, as maybe one of the optimal options that would be superior for young people, or one of the options that would be best for young people. And then I also wanted to comment that young people are scared of your adverse events, in which they're so-called your side effects. Most of young people are cautious if maybe they're not clear if these preventative methods or contraception methods won't really their health, because they need extra information to secure their conscience around them experiencing side effects. So there's a conversation, maybe that there's an unsettled conversation of securing young people's conscience on adverse events. And then I also wanted to talk on the conversations of males not wanting to access healthcare services. We have a huge gap of young males not really wanting to access healthcare services because of them wanting to maintain their social lifestyle. They think going to the clinic is has a lot of stigma, especially for a man, and other social elements that are against men accessing healthcare services. So if we could work on reducing stigma for men to access their healthcare services, and other patriarchal norms and cultural norms that translate to GPV, especially with women. Most of the young women are being forced to have unprotected sex by their partners. Most of these young women are being forced to maybe don't maybe have raw sex, or maybe don't use a condom, or maybe demanding to have a child. So we have those toxic masculinity conversations that we have to address in in our communities. As I'm wrapping up, the wording that is being used, especially in our healthcare facilities, young people are not really into clinical terms. So if maybe we could have more friendly terms for young people to access that information that is being offered in our healthcare facilities or even by healthcare promoters, or maybe even explore possibilities of having local languages to support that comprehension of our communities. And then I also wanted to tap on the conversation of having lack of young influential ambassadors or advocates in our healthcare services. We need more young people who are influential, or even more ambassadors who are influential in these spaces to support literacy, or even to support the motion of HIV prevention and pregnancy. I think I have talked to most of what I highlighted on my key points, and then I think I'm done. Thank you so much, Sesona, for the platform. I tried by all means to cover most of what I have planned. Thanks.
Thanks so much for your insights, Nico. And we will now move on to the question and answer session. So just a reminder, you can pop your questions in the Q&A platform or even in the chat. I see we already have a question from Busisiwe Ngala Dlamini, which asks, are you not overusing the concept innovative? Anyone who has given a thought that we have different types of young people every certain period, be it 5 or 10 years, as influenced by socioeconomic circumstances at a time. I'm not sure who would like to answer that question. It wasn't specifically directed to any speaker per se. But yeah, any one of our speakers who'd like to answer that question?
Sesona, I would like to please respond to that, and perhaps to say loosely, we've used the word innovative, and I'm in agreement. And perhaps the terminology, as Nico was speaking, is also some of what we need to observe as a blind spot. So by innovative, in reference to what I was saying and in agreement to what Tanya had said, innovative and progressive biomedical therapies would perhaps be supplementing that with adaptive. So you gave the example of 5, 10, 1, 3, 15 years back. What we need to do is to have adaptable advances, adaptable interventions that speak to the realities, that speak to the transforming spaces around society and economies. So let's interchange on my side and my use of the word with perhaps adaptive, progressive, fluid, so that it was just in reference to say not stagnant. We need to rethink. We need to have inclusive approaches that consider other things just past what we have been creating interventions based on.
Thanks so much, Nga. Is there anyone else who'd like to take a jab at that question, or should I move on to the second question?
Sasona, can I just add to the question on age? Great. So just speaking from a more research sort of perspective, I think that's a very good point to highlight that we get different groups of young people and they do face very different challenges. We've also found that in one of our other recent studies where we looked at participants between the ages of 12 and 17, and depending on which age group they fall in, they do face a lot of different challenges in terms of transportation, independence. So I think it is important to look at those different groups and their differential healthcare needs as well. So thank you for pointing that out.
Thanks so much, Tanya. I will move on to the second question from Busisiwe, which asks, or rather, they start off by saying, "Thank you, Nico. What role does alcohol play in young people's behavior and health-seeking behavior?" Nico, would you like to take that question?
Having technical issues, as this question, the one that I'm reading on the comment, what is his view on the impact of age priority appropriate sexuality education at school? I know that the classroom is not necessarily a safe space, but how can it be improved? Am I answering that question?
You can start with that question, and then there's another question in the Q&A feature, which asks, what role does alcohol play in young people's behavior and health-seeking behavior?
Well, let me first take this one. I think, according to my personal views, the impact of age appropriateness in sexuality education at schools is it's quite a broad conversation, because not all of those young people are exposed to our Western interventions. Most of these young people have home backgrounds that are culturally driven, and especially with cultures that are against most of these sexual reproductive health literacy in schools. So there's a need and a gap for us to intervene in such services, because they are appropriate, especially looking at our generation. We know that there's a gap for us to improve, and there's a gap that we need to fill by including these interventions in our education system. So I support the motion, but it's something that needs to be specially tailored in a special way that would address young people's needs, especially those who are at schools. Thank you.
Thanks, Nico. We have two more questions for you. Just starting with the question of what role alcohol plays in young people's behavior and their health-seeking behavior. And then I'll just give you the second question once you've answered that question. Hi, Nico, are you still there? Okay, it seems Nico's unable to answer the question at the moment. We'll just move on to the next question from Sinesipho Schreiber, which asks, and I think you can answer this, Tanya, did the study find the perspectives of young people prioritizing birth control rather than HIV prevention? Did it find this to have been prevalent in poor areas?
Thank you, Sasona. So this study didn't look at the different socioeconomic status of the participants involved, so it wasn't analyzed in that way over different socioeconomic statuses. But just to give you an indication of the participants involved, they were recruited from townships and inner city metro areas, which are generally, according to the study description, less affluent areas. So that was the participant group involved, but they weren't compared across socioeconomic groups.
Okay, just a note that, okay, I see your hand, Mandy. I just wanted to give a note that Nico has some technical difficulties. His laptop switched off, but once he rejoins the call, he'll be able to answer the questions that were asked by you, Busi. Mandy, you had your hand up. Did you want to take a jab at that answer?
Yes, I wanted to maybe just add to the question that was directed to Nico about how alcohol influences the behaviors of young people. I wanted to talk about it maybe on the perspective of what healthcare workers experienced and observed. And I want to take us back to COVID. During the time of COVID, when we had a ban of alcohol, you could see the headlines. Most healthcare practitioners were saying that our emergency departments are seeing less numbers of people because we do see the active, relation between alcohol, trauma, and let me say ill social behavior. That link between the two. So when it comes to sexual reproductive choices, it's a known factor that the concussion of alcohol and sexual reproductive health, ill choices and behaviors are closely linked together. That if you have the two together, you're gonna make a bad decision. So it is something that is there. It is something that we are all aware of, that alcohol does then influence poor choices when it comes to sexual and reproductive health. However, I think what is interesting to think about is why is it the solution of young people in terms of what they pick as their recreational activity? And that also speaks to a large part of how our societies don't create enough recreational activities for young people. You have a lot of recreational activities that are party-based. So you'll see even when the government makes an event for a specific celebration, it's an event, they speak, and then people drink and have a party, rather than activity that has a long-lasting impact, or a week of just sport, etc., to get young people involved in understanding that that's also another form of entertainment. So this can have a lot of aspects of conversations spoken from them. But I think just answering the question, definitely yes. The presence of alcohol and young people seeing alcohol as the priority source of enjoyment or entertainment greatly affects their health behavior and health choices, and not necessarily for the positive, but for the negative. That could assist.
Thanks so much, Mandy. There's a question in the chat from Duduetsang Medi, which asks, to Tanya and Sasona, I recently saw that IBIS launched a toll-free helpline offering SRH referral services. Can you tell us more more about how do we call? Tanya, I think I'll take that question. So we, through our Moho campaign, have launched a helpline, an SRH helpline, which is targeted at adolescent youth. I will just share the screen and just give you some details on that. So we recently launched a helpline, an SRH helpline, which is a referral helpline where we offer referral services to young people and adolescent people for SRH services, sexual and reproductive health services. These services that are offered are GBV and sexual abuse services, safe and legal abortion services, pregnancy and contraceptives, LGBTQIA plus services, HIV and STI services, as well as mental health issues are referred to. So what happens is someone who needs help for or needs an SRH service, for example, wants to access a safe and legal abortion, they call into the helpline, and our helpline agents are able to, based on your area and location, locate you to the nearest available facility, and you can choose whether it's a private facility or a public facility. We have a nationwide database of all these facilities, and we will give you the contact details and the address of where the facility is. I know one of our speakers actually mentioned, touched on COVID-19. So the reason that this helpline was launched was due to the fact that young people were unable to access or had difficulty accessing, SRH services during the pandemic and during the lockdowns. And so to address these issues, we made this helpline available. The helpline is toll-free. So if you call in, it is free and you can get access to these services. You also get information on SRH resources and the Moho helpline and the campaign. Operating hours, Monday to Thursday, 9 o'clock to 8 o'clock in the evening, and then Friday to Saturday, 9 o'clock to 5 o'clock. And you can call into the helpline. You can also call after hours and the help and leave a voicemail, and the agent will contact you as soon as they can. The cell phone number is 080-001-4597, and I'll also put it in the chat if you'd like to copy it, and you can scan the QR code for that as well if you're able to. And thank you so much for that question. I think we have one last question from Busisiwe, which says, Nyeko mentioned something very important about the lack of monitoring. The presenters did not at any point refer to the fact that in South Africa we had Love Life and YFS. So what did work and not work then? Because I am listening to the recommendations pointing to that direction of YFS again. Is there any speaker that would like to take a jab at that answer? I'm sorry, that question. Over to you, Nga.
Thank you, Sesona, and I think it's such a pertinent question, and again speaks to how can we have young people involved in the decision-making process. As Nico gave his presentation, he touched a lot around the gaps and how the invisibility of young people contributes to the success or lack thereof in these services. Mandy spoke about how there are youth-friendly services within healthcare facilities, but young people don't know that these are accessible to them. So as much as we are advocating for youth-friendly services, some of the things we have to do is go back and review the failures of what was there before. And one big one is the lack of inclusivity in the drafting and the implementation of this, of these programs. We know peer-to-peer mechanisms have been proven to be very effective. We know going into communities and addressing different realities have been proven to be very effective. So, we can't be saying that 20 years post CSC implementation, for example, we're still trying to redress the same kind of approach. We need to accept that that particular model has failed. So how do we then strengthen it? And, one of the things we do at AHF across Africa, and we're starting it in South Africa, is community power voices. How can we learn from the communities? What are the gaps? What are our misconceptions? What is our oversights? So, for example, people like Mandy in healthcare facilities can tell us, why are young people not coming to the healthcare facility? On our end, as an implementing NGO for HIV services, we're seeing that it's the attitude of healthcare workers. But we can't connect if the Department of Health is not coming to the table. Young people also need to tell us that actually it's not the fact that the healthcare workers don't have a positive attitude towards us. It's what happens when I receive these sexual reproductive health services and I have to go home. And how am I then going to see this through? If it's a pill, for example, how do I hide this from my mother? So those are some of the dialogues we need to open up. And the strongest recommendation I would give is we need to step back as saying that we have the answers. We don't. We need to learn from the young people, and we need to foster dialogues with young people intently so that we can learn and see why we have failed for 2 decades.
Thanks so much for that, Nga. We have another question from Spiwa Machoba, and it is directed at all our participants. The question is there a model document that defines safe space in healthcare facilities so that we can use it for monitoring purposes? Anyone who'd like to take a stab at that answer? Hi, Nico, can you hear us?
Yes, I can. Can you hear me on my end?
Yes, I can. Would you like to
Perfect.
answer the question by Mr. M?
Can you
Hello, can you hear us?
I'm having some technical issues, but I'm back online.
Okay, I'm actually seeing a message, an answer from Nga. She says we would be happy to work towards developing one as AHF if it needs a review or needs to be birthed. So that's the answer to your question, Mr. M. The question regarding model documents, she says that they would be happy to work towards developing one as AIDS Healthcare Foundation if it needs review or needs to be birthed. We have one last question from Busisiwe Nkala, which she starts off by saying, very good helpline. What informed the times? GBV happens midnight to early hours of the morning, and there is also free services between midnight and 6 a.m. Just an addition on how we position these services. So what informed the hours at the moment, we are still expanding the helpline. The helpline launched in December, on the 1st of December, on World AIDS Day. But we are still working on advancing and expanding the hours of the helpline as we grow. I think when we started the helpline, it was just a normal 9 to 5, Monday to Friday. But as we grow and as we expand, we will be expanding the operating hours as well. I think those are all the questions that we had. If there aren't any more questions. Okay, I see Busisiwe Nkala has also directed Spio to check UNICEF and the World Health Organization documents for the question regarding model documents to define safe space in healthcare facilities to use for monitoring purposes. Thank you so much, everyone, for joining our webinar this afternoon. Thank you to our speakers for sharing your insights. Thank you to everyone who availed themselves to join the webinar. Thank you so much to everyone who asked questions and engaging in this webinar. It is through these discussions such as these that we're able to empower young people to learn more and take advantage of their reproductive health rights. Thank you so much for joining, and we hope to see you again at our next webinar. Thank you, everyone.
Thank you, Sesona.
Thank you, Sesona.
Thanks, Tanya. Thanks, Mandy. Thanks, Nico.
Thank you. Bye.
Thank you,
Bye.
everybody.